Okay, so ladies and gentlemen, now for something completely different. Let me engage in a little bit of frobbing to just make it full screen here. Okay, so I'd like to share with you some thoughts about system science more generally, bearing in mind that our time together is very limited, and so much of today is about triage. My colleague Jeff McDonald tells me, so I teach these 6-day-long boot camps here, right over there, the building over there, every year in August. And he tells me that the biggest challenge to boot camps is figuring out the 90% that I don't talk about. Because I can only talk about one small portion of it. And really it is a matter of triage. In this case, it's not about only being able to provide 10% of it. It's being able to provide something like 2% of the pictures. But I'll try to convey a few essential features here, okay? So, ladies and gentlemen, for years in the health sciences, we've been dealing with a technique that has yielded great benefits, great value, and will continue to offer tremendous insights. And this technique is predominantly reductionist. We take things apart and figure out how the pieces work. And this plays out differently in different contexts. We in the lab sciences, we take apart the genome, and we figure out how particular pieces of the genome work, and we use that to develop an insight into the biological pathways operating, for example, that mediate expressions of genes, etc. Very powerful strategy. In the context of epidemiology, we take particular associations involved with certain outcomes, and we study them very carefully. Perhaps we study RCTs for randomized controlled trials about the outcomes of treating someone with a drug to understand exactly how does this drug change, the risk of heart attack on a per year basis for people of different ages, for example. And this strategy is fantastic. It's offering profound insights into how mechanisms work in isolation. The challenge is that increasingly confronts us, and the challenge that I know the NIH and the CDC and the states have been grappling with now for over a decade is, how do we put these pieces together? With the Human Genome Project, there was a lot of millennial thought that once we take apart the genome, we have the keys to the kingdom. We know how things work. If we can sequence the genome, we're going to be able to have a really good understanding about why disease comes up. And one of the things that folks realized is that that's just the start. I mean, it's a great start, but there's a whole level of functional genomics and proteomics and gene by environment interaction, et cetera, on top of that. And really, it's increasingly people recognize it's not just the pieces, but the connections between them. And much of the patterns that we see in the world come about not just because of the pieces, but because of their interactions. One example I'd like to give for my students is traffic jams. We could know everything there is to know in the world about how a car works. How its wheels operate, how the braking system works, how the engine operates, and the manifolds on the engine. We could have all sorts of information about that. And yet we'd have limited understanding of why traffic jams form. Because it's not just about those pieces. Surely those pieces have something to do with it. After all, if a car breaks down every 5 minutes, it's going to have some implications for traffic jams. But knowing everything there is to know about how a car works does not give you great understanding as to why traffic jam forms, every day on the University Bridge coming back from town. Cars are a piece of it, so is something about the road width, so is something about the curves on the roads that apply, weather conditions, the psychology of driving, how close people feel coming close to each other. All these things kind of tangle together to yield traffic jams. And if we want to solve the problem of traffic jams, if we want to reduce traffic jams here in the city, we need to consider those different pieces, not each in isolation. And you know, when it comes to areas of health, there's similar issues. I mean, people have realized that RCTs can give great insight into some particular areas of outcomes from a drug, but for full effectiveness in the community, often RCTs really fall short. They control for many of the key issues that really mediate the outcomes in the community, whether someone complies with taking the medication, the degree to which they're taking it together with other drugs that interact with it, the degree to which a person is willing to tolerate the side effects or to even initiate it and ask their physician, or to be open to their physician's recommendation to take it. In short, when it comes to even things like RCTs, where there's a gold standard of evidence, we know that the actual effectiveness in the community often is quite different from what we measure through the RCT, because all these factors that are controlled for in the RCT are in fact key factor, or are often key factors in mediating success in real application of the pharmaceutical. So we have systems level phenomena that apply in many different systems we work with, and health is one of them. And I'm going to be focusing on some of the health side components of this over the next few minutes that are illustrative of some of the challenges of complex systems, and as far as understanding a system and as far as changing the system. My colleague Bobby Milstein, who at the time he articulated this was at the US CDC, he talked about public health being about redirecting the course of change, trying to change, to bend the curve, to improve the health of the population. And for many years, I was doing work in the STI area. Some people who are here now probably remember much of our work there, and it's still an area we publish in, although at a less common rate. And through the 90s, for example, if you look at this is from Tom Wong at PHAC, there were declining rates associated with reported cases of chlamydia. And there was a certain degree of congratulations because these were hard won. There were a lot of efforts that went into reducing the incidence of chlamydia within the population in terms of safe sex campaigns, in terms of improved diagnosis strategies, nucleic acid tests, for example, that came in just at the end of this time to replace some of the more invasive measures previously, some of the messaging campaigns, and so on. But if we look after that period, a lot of those decreases in incidence that we saw were reversed. And there were a lot of questions at the time, why? Why are we seeing this rise? And there's a lot of comments of this being a crisis situation, that we're reaching levels of chlamydia in the population in terms of prevalence among individuals that lead to very high rates of incidence that were seen as really very worrisome. Now, if one looks at this data, it's easy to interpret it from the point of view of an alarm. It's also easy to recognize that we are seeing, not only across our province, but across Canada, these rising rates. However, the full reason behind these is not evident. Changes in reporting, for example, could be behind some of these rises, as well as changes in the incidence of the underlying infection. So if we want to know what's going on here, is this good or bad news? Is it possible these rising rates are actually indicative of finding cases that previously were going unmentioned? And if we want to know how can we bend this curve to reduce these rates, these are things which are hard to address using traditional techniques alone, where we have these set of factors involving diagnosis, care seeking, involving transmission, prophylactic measures, changes in diagnosis technologies, and changes in sexual behavior, which are tangled together. They're tangled together in a way that yields that data. And when we're trying to reason about this tangling, a lot of the techniques we use to take apart the system, for example, regression-based techniques, are not going to give us the level of resolution we need to understand how these different factors contribute to rising rates. Reductionist approaches have supported this understanding of the pieces, but they're going to have challenges when translated into an understanding of the whole. And I'd like to talk about a couple examples of this. Diabetes and obesity is an area that we've worked for years. Many of you know our publications, American Journal of Public Health and CMAJ, on this front. And as we know, for obesity and diabetes, not only is obesity multifactorial, there's multiple types of things, nutrition-wise and physical activity, sedentary behavior-wise, that contribute to it. But there's different levels of context that end up affecting it. It's not only complex physiological regulatory processes, the fact that once one gains weight, it's harder to lose it again than it was to get in the first place. Regaining it, in short, is easier than gaining it the first time. There's diverse actors that play in this. Fast food retailers, agricultural producers, consumers, the weight loss industry, city planners that shape the urban form, etc. There's a key role of the environment here. People have long identified social network effects that affect someone's physical activity level, affect someone's eating patterns. People tend to eat more in groups. They tend to eat more if they're given food on large plates. Aspects of the built environment, the food environment, all play a role here. There's shifting norms, attitudes, beliefs that play a role. And then there may be gene by environment interactions, some of which we focused on with respect to gestational diabetes. Same thing with heart disease and tobacco, right? We have tobacco and its causative impact on lung cancers, for example, fairly well understood in terms of the biological pathways. But in terms of understanding changes in tobacco use over time and their interaction with e-cigarettes, it's a really tangled mess. This is one of the reasons we're pleased to be cooperating with PHAC on understanding and teasing apart this interaction of e-cigarettes and cigarettes, because it's a very messy situation. We have some particular biologic layers, but we also have layers involving economics of tobacco, physiological as well as psychological, regulatory processes, use of cigarettes as a stress, a sort of self-medication for stress, diverse actors, once again, role of environments. So, smoking is a social disease. Koopman said it probably 15 years ago or so, Jim Koopman at Michigan, and it's really true. And once again, there's physiological, psychosocial, and psychological effects. So, when we're dealing with these systems, this is a nice graph from Sandro Galea, my colleague at BU School of Public Health, where he was illustrating the different layers of factors that are involved in the food system alone, for example. And this is from Shariki Kumnaika, who is a colleague on the Network for Inequality, Complexity, and Health, and her articulation of factors that end up affecting obesity and overweight from the level of an individual all the way back to international factors involving international trade and globalization, et cetera. This from the Foresight Institute. Really what we're seeing here, ladies and gentlemen, is something where we're dealing with a system where the whole is greater than the sum of the parts. Interaction of very simple components can sometimes lead to very surprising overall patterns. Just like you take a car, you take a bunch of cars, which individually seem fairly straightforward to reason about, but together they can form traffic jams. And the patterns that you see at the overall level, a traffic jam, are very different from what you see at the level of an individual car. It doesn't make sense to talk about, a car as being jammed, but it sure applies to the whole system. And so it is with a lot of health issues too. The factors that we see at the neighborhood level or at the level of a whole city or region are very different from what we see at the level of an individual or family. and reasoning about the multi-scale nature of effects and how those effects at an individual level involving cigarette use and e-cigarette use, how does that ripple through to patterns in the whole population? It's a messy situation. It's a situation that involves a lot of complexity in these different layers. And while we can use hierarchical linear modeling, methods that involve different levels of scale, statistically, they don't allow us to ask how do this tangling of different factors lead to ripple through to these emergent behaviors we see. So I'd like to highlight two particular things that are really troublesome with traditional methods. One is to explain what's going on. And here, this is a very constant refrain. Does the evidence support my hypothesis about what's happening in the population? Is the evidence, for example, involving those rising rates of chlamydia suggestive of Brunham's arrested immunity hypothesis, that maybe we're treating people too quickly for chlamydia and we're blunting their development of immunity to chlamydia? Maybe the problem is, in terms of rising rates of incidence, that we're taking people, we're treating them quickly, throwing them back into the population, and they tend to get reinfected, where if they were treated less quickly, maybe they develop immunity, and once they were treated, they wouldn't get it again as quickly. That was Bob Brunham's theory, as articulated by the BCCDC. He was director of the BCCDC, I think remains there. And it's an intriguing theory. To what degree does it line up with the evidence? Well, it's not clear, because the evidence involves this tangling of many factors together with this. Where's the situation likely to go next? Are those rising rates of chlamydia or gonorrhea likely to continue to rise? What's driving these patterns? Is what I'm seeing a good or bad thing? Are these rising reported cases, is that good or is it bad because there's greater incidence? Is it good because we're discovering people who are at risk? When we're dealing with health, we often see a lot of patterns. This was noted back in the 1700s by Bailey in the bubonic plague from London. This characteristic curve, which we recognize so well now as sort of characteristic of outbreaks. The epidemic curve. It's kind of this bell-shaped curve where one infection breeds 2, breeds 4. You get this escalation and then sort of a drop-off later as the number of susceptibles are depleted. And we know for childhood infectious diseases, we've seen patterns of complexity since before the era of vaccination. These kind of patterns of measles and mumps over here in England and Wales and over there in Saskatchewan in the decades before the introduction of MMR. Here again we have these kind of puzzling patterns. It's not quite regular, but it's not totally irregular. There's some orderly feature to this, but there's also a lot of stochastics. What's going on behind this? Why do we see this? Is it likely to continue even after vaccination? Is it likely to reemerge as we see waning levels of vaccination due to vaccine hesitancy and vaccine resistance on the part of individuals? We see factors where we have coupling between different individuals. We do some work in infant and maternal mental health, and the coupling of the mental health with postpartum depression and infant mental health are quite profound. And Christakis and Fowler have pointed to associations at the level on networks, even for diseases like obesity, which we're not used to thinking of them as communicable in any form, but there are profound associations involved with networks. And for chlamydia, this is for Regina, I think, we see real spatial patterning involved. For chlamydia and gonorrhea in Manitoba, and spatial spread of zoonoses like rabies. So ladies and gentlemen, here, a lot of the challenges, we may have theories about the population, but we don't understand from those theories directly. We don't have a good way traditionally of asking what's the implied dynamics of that theory. We have this theory about how things might be operating out there. Maybe it's Bob Brunham's his arrested immunity hypothesis. What does that imply about what we should see so that we could, for example, compare it to empirical observations? Traditionally, this has been a hard thing to understand. We have this theory. To what degree does it imply things that are consistent with empirical observations? That's a hard thing to know because this is so tangled. Okay? It involves an entangling of many factors. The second big need here is one to intervene. Where to intervene? How to intervene? How soon should I see effects? How can we scale up these effects from an implementation science standpoint, from a small scale to a large scale? Will they be sustainable financially from a human resources perspective? So when we need to intervene, we're talking about intervening in complex systems, and systems where the whole is greater than the sum of the parts. And we may want to intervene in areas which are involve bridging individuals who have that special role in bringing an infection from one area to the other. This is from Asad Al-Azem on the TB front. TB structure here in the province from some of our work. Existence of TB and other infectious diseases like chlamydia network cores is well documented. We know from some of the epidemiology involved that we see profound levels of disparity in some of the risk factors across the population. And it's posited in core network theory that some of these individuals who occupy a fairly small segment of the population may in fact have a driving influence on the ability of an infection to survive, where otherwise would disappear from the population at an effective level. So it may be those individuals out here on the right-hand side with lots of connections, for example, that might allow chlamydia or gonorrhea to survive, probably more gonorrhea, over a longer period. In some sense, the tail that wags the dog is the hypothesis here. Here, when we're thinking about intervening, perhaps these groups are of particular interest, but we've traditionally lacked ways of going from a theory and thoughts about what interventions we might select, to examine what are the implications over time for those, and to be able to then ask to what degree those consistent success of this intervention, is it consistent with data that we have coming in during an intervention. So once again, in reasoning about how the tangled system will react in the context of interventions. Okay, so, if we want to put into place, as my colleague Jeff McDonald talks about, getting fixes that stay fixed, putting in place measures that are going to yield gain over the long run, we need to reason about this complexity. And it's a complex world. We have tipping points, cases where if we can just invest enough, we might see a qualitative change. We talk about herd immunity for infectious disease. That's a systems issue. Each individual in the population there may be plenty of susceptible levels, people in the population, but herd immunity is not about the pieces, it's about the whole. It's about, is the system as a whole resistant to the intrusion of infection? That's an example of an emergent phenomenon, and it's an example of a systems effect, okay? We see other effects, path dependence. So, if you scar a child with a traumatic experience, it may affect that child in later life. I don't know if you folks have familiarity with the Dutch famine study, for example, the terrible effects of the Dutch famine following World War II, and the lifelong effects that are felt by individuals subjected to that. Some of the work that Barker did in Manchester, documenting the effects of early life insults in terms of deprived conditions on chronic diseases into people's 60s and 70s, so many years later, controlling for many factors. We see many of these effects here in the province, unfortunately, when it comes to things such as risk of diabetes. But these are examples of path dependence. We don't just forget things that happened earlier. Sometimes our bodies remember. There's path dependence. The trajectory we're set on, unless we intervene in judicious fashion, can continue to diverge because of early life insults that we've suffered. So, when we're dealing with traditional techniques, biostatistical techniques that rely on teasing apart pieces of the system, we can get tremendous insights, but we do have limitations of those techniques to deal with many pieces. tangled pieces where we have many factors coming together. We have multi-level and multi-pathway health ecosystems. We have reciprocal causality, where there's a person's feeling socially estranged may lead to emotional eating, may lead to obesity, which furthers their social estrangement, for example. We get these reciprocal effects. Poverty and substance abuse is another one where we have very big reciprocal effects. When we're seeking to undertake novel interventions, there's no data available about what changes they will lead to. It's hard to perform statistics when there's been no data generating process to yield the data. We want to understand life course effects and path dependence. We want to understand disequilibria, tipping points, adaptation and learning on the part of an individual. We want to understand the effects of norm shifts or feedbacks, both positive and negative, both reinforcing and balancing. These are all complex systems challenges, and if we can't confront those, we face a lot of difficulties. We face misperceptions, we misinterpret the data, we face policy resistance. We undertake a policy and it yields net negative results or much less gain than we hoped. We stumble across tipping points where the situation becomes untenable, and we have trouble learning from experience, coordinating, designing, and planning effectively. And there's a long series, I've got to show this is from Bobby, a long series of conditions where in health, we try to escape one type of adverse outcome and we end up leading on to another. We saw that in the States in a big way in tobacco. The US decided that one way to lower the health burden of smoking would be to institute low-tar cigarettes. Thinking being, if you have a smoker and they're smoking cigarettes, if we could get less carcinogens packed into those cigarettes, we could avoid a whole swath of health harms to which they'd be exposed. And they rolled out low-tar cigarettes in the States with the hope that it would really lower the burden of heart disease and the ripple-through effects of death, particularly for older men. And it turns out that the consensus now is that it did net harm. Why? Because, yes, it probably did lead for a given smoker to less exposure. However, a lot of people who would have quit probably ended up continue smoking. They thought, well, just, quitting is really hard. Nowadays, I can switch to low-tar cigarettes, and I'll be doing less harm to my body, and they probably stayed as a smoker. And so the thought is that, yes, it probably did yield net health gains for those who would have been smokers otherwise, but for others, it probably significantly depressed the cessation. It's an example of this sort of entangling where we try to avoid, one adverse outcome, and we end up, instigating another. And that's how it is if we don't understand why we're seeing effects in the population and how our interventions might affect things. So the reflection on this, and I'm going to try to get you to the break here in just a little bit, is that the sort of way that system science pursues addressing these challenges is to reflect that the patterns we see in the population, the patterns over time, are reflections of underlying processes. They're reflections of some processes out there in the world that we only indirectly observe, and these processes are tangled together. And to truly understand why patterns persist that we see, to understand those rising rates of chlamydia, or understanding those patterns of spatial patterning associated with chlamydia or with rabies or what have you, we need to reason about these processes that give rise to them. The data generating process, to put it from a statistical perspective, the thing that gives rise to the observations. And system science in the past 15 or so years has been the concerted attempt to try to address this need. And I like to call it the science of the whole. It deals with the whole rather than the pieces. And it can help us try to reason about how these underlying processes give rise to the effects we see in the world and the ways in which our interventions will change it. And one of the biggest ways it does this is through the use of dynamic models. And these models, by representing how things might be working in the world, they help us serve as thinking tools and share our assumptions with others. These are some of the factors we often see in the world that motivate a system science approach. I won't dwell on this, but these are kind of the hallmarks of complexity. When we see feedbacks and path dependence, interagent effects, emergence, factors which at a high level are very different at a low level, these often indicate the presence of the sort of whole is greater than the sum of the parts. So what are these dynamic models? Simulation models, like the one we ran earlier, they represent hypothesized causal relationships involving diverse factors, how these factors relate to each other, how one thing affects another over time. And note the emphasis on hypothesized. Models are not sure things, but they help us more quickly identify mistakes in our thinking. So they help debug themselves in a way. They help provide a way to examine the diverse system-wide consequences of changes in one part of the system, like lowering relapse rates. How does that ripple through to changes in the number of children exposed in utero to nicotine? How does it ripple through to the prevalence of smoking within low-income individuals? And these models help us and other system actors identify vulnerabilities and leverage points in the system, ways of changing the structure and working together more effectively. Now, one of the really difficult things about working with these sort of models, as you start getting into this space, is they go by different names. So I will rattle off here a bunch of names for these sorts of models. Two of them are written up there, mathematical model and causal model, in addition to dynamic model. However, you will see other names used, mechanistic model, a model of the physics of the system. People talk about particular subtypes of these models, agent-based models, microsimulation models, system dynamics models, compartmental models, discrete event models, discrete event simulation. All of these are examples of these sort of models. They're a clade. They're a group, collectively called, I like to call them dynamic models. Causal models is pretty overloaded these days, as you know. There's a wonderful, and I think it's fantastic stuff, set of interest in causal models at a statistical level that is conceptually related to this, but it is different. There's a lot of commonalities in terms of the causal thinking involved, but the point is they don't go by one name. So if you're to do a literature review related to dynamic models, relating to e-cigarette use, you will want to search under many different terms because different sub-literatures use different names. But the defining goal here is to understand dynamic behavior that results from hypothesized causal structure. So we posit these processes are going on in the world, and we ask what is the implication of that over time. They're mechanistic in the sense that they depict what changes what in the system, or what we hypothesize to change what. And this is why people talk about them depicting the physics of the system. They're not just characterizing the associations, they're characterizing the causal pathways that are hypothesized. Okay? And normally, there's a large part of that that's latent, that we don't observe directly. We indirectly observe it. And here, critically, they simulate the step-by-step evolution of the state of the system over time. We run them out. Remember that button we press to run? It runs out over time. We see that population as it goes from time step to time step to time step as it evolves over time. We're simulating a micro world of people over time. And because this captures, and I would have put in there, but I ran out of space, hypothesized causality, we can anticipate outcomes for counterfactual situations as implied by this model. So we can take a model like this. We're saying, this leads to that, this other thing leads to this other thing, that, my having a certain number of connections that are smokers leads to this change, my hazard rate of uptaking. That allows us to ask about counterfactuals, where, we might change the nature of the environment, the social environment, and see how it ripples through to the model dynamics. Now, in other areas of industry and practice, this stuff is old hat. I would never want to fly on a plane, a commercial airliner, where the pilot hadn't undergone thousands of hours of pilot training. in a flight simulator. It would be crazy, it would be a point of madness to have them actually fly real planes into thunderstorms to understand how it behaves under the wind conditions. Instead, you use flight simulators. It's risk-free. We get their intuitions going. We get them to understand how a plane behaves under wind shear and under heavy precipitation and ice on the wings. We do that in a flight simulator, and so it is for many other areas. When people plan city streets, they use traffic flow simulators. But in health, this is a newer idea. These topics are newer to the table, and so there isn't that historical reliance. But right now, the interest in these sorts of models is exploding. I mean, my group can't keep up with the number of opportunities out there, and it's a worldwide phenomenon. What do these models do? Well, my colleague Jeff McDonald uses the term, he talks about them as thinking prostheses. By prostheses, I mean something like a crutch. In what way are they like a crutch? Well, ladies and gentlemen, we have limitations in the world. And when we break our leg, we have limitations getting around, so we use crutches. Our limitations that our models help us deal with are limitations in our thinking. They help us complement, just like a crutch helps us complement our strengths so that we can get around. It lets us use our good leg and still get around. Simulation models help us complement our limitations in our thinking about logically what's the implication of a theory to allow us to reason about that implication more consistently, quickly, and thoroughly. If we had to go take this theory as depicted in that model we saw, unfortunately I closed the model, but you saw as a fairly articulated theory, we could have Einstein sit in front of that and feed him a description of that theory and ask him what's the logical consequence over time for the number of individuals who are currently smokers in low SES group. And he wouldn't be able to figure it out because humans just aren't wired to do thinking consistently about theory at a quantitative level. But models can help us do that. They can help us do it quickly and thoroughly in ways that are consistent. Computers are really, really good at doing dumb things over and over again. And this is one of the things they can do. They can simulate. If we give them a theory and we state it unambiguously, they can tell us what the implication is over time. And this allows us, this is not independent of empirical data. We can, because of this model, we can put whatever empirical evidence we have to better, more complete, and more effective use. We can ask to what degree does our theory lead to implications that match our empirical observations. We can say, okay, if these empirical observations are reliable, maybe we can use them to put assumptions into the model about the current state of things. We can use these empirical assumptions to test the model's ability to accurately describe the situation. And we can use it, in some cases, to refine the model's guesses as to parameters. These models can also help us communicate our assumptions to others. The fact that we take a theory out of our head and put it into an unambiguous form allows others to critique it. It allows us to put it into the common domain where people can refine it, critique it, examine it, and improve it over time. And it takes it out of our head where it's trapped and it's opaque, and it puts it into a form that allows us to share it. So these models can help inform our actions, our choices, and inform our understanding. They're best used together with observations about the world, observations that often check model predictions, what we think is going to happen now when we institute an intervention, with what actually happens to improve the model, improve our thinking. But fundamentally, they are thinking tools. They help us think through the consequences of our best guesses about what's going on in the world and test those consequences in a faster way than we'd be able to otherwise. So they make explicit these mental models of what we think might be going on in the world. They can aid learning faster and more deeply from evidence and in management of complex systems. Particularly asking what-if questions on novel situations we've never seen before, therefore we don't have data on which to perform statistical analysis, to evaluate benefits of restructuring a system, to understand trends, prioritize research, prioritize data collection. We can identify which parameters seem to have the biggest impact on outcomes, and identify classes of contexts where we can adapt reasonably strategies from one context to the other. So what do these models depict? They depict the behavior of the system over time, the evolving state of the system. We can run it, stop it at a given point. That's the posited state that will apply at that point in time. And they specify how the model will change given its current state. Given that you're in a former smoking state, what things can happen to you? Well, you can relapse. Given you're in a never smoking state, what things can happen? Well, you can initiate smoking. System behavior is emergent. It's not something we put into the model. It tells us rather than we tell it its type of behavior over time. That stands in contrast to statistical models, which might posit a certain form, a certain formal form over time as a basis. Maybe it's a linear trend in time. Great models to work with, but here the system behavior is emergent. It comes out of the model, and it can't be pre-specified. In general, it's not something which is amenable to description in a so-called closed form. The example I like to use for this, and I'm trying to wrap up here, is models are like maps. All maps, ladies and gentlemen, are simplifications of the world. They're abstractions of the world. They hide certain details and show others. And it's the ability to hide details that makes a map useful. The fact that it can fit in your car is because it's omitted all sorts of details that isn't germane to your needs. But like maps, models are specific to purpose. So with a map, we use a different map if we want to understand why flooding is occurring near Wascana Lake in Regina or on White Swan Drive here in town. We'll use a different map than if we want to figure out why brownouts are occurring on the west side of the city, or if we want to figure out how to best drive through the city or cycle through the city. Those lead to different maps. We use different maps which show different aspects of the detail. And so it is with models. Models are specific to purpose. What our model includes, what it leaves out, will depend on our goals, what we're seeking to get out of the model. And all models, like maps, just as George Box said about statistical models, all models are wrong, but some are useful. They're wrong in the sense a map is wrong. It leaves out the blades of grass, next to the sidewalk. It leaves out an indication of which streets are one way, but it can be really useful to drive around town to have that map. Models, dynamic models, like statistical models, all have limitations associated with them. And often it's a learning process, just like with statistical models, we might perform stepwise regression. With a dynamic model, we will perform refinements of our model scope over time. Francis Bacon once said, "It is easier to evolve truth from error than from confusion." And that may seem like a bizarre statement. I mean, surely being wrong is worse than being confused. Well, what he was saying is basically fail early, fail often. Try something. Even if it's wrong, you've learned something. If you just sit back and muse, you're not going to be going anywhere. You're not going to be learning something. Models, ladies and gentlemen, provide us a way of taking a theory, encoding it, asking what are the consequences, asking does that make sense in light of our observations? Is that consistent with our evidence? They provide us a way to be transiently wrong, and it's better than being perpetually confused, than just not being sure what's going on. We try something, we test it, and we refine it, and we correct it. So they're tools for learning. Common concern here is the model scope, and I want to highlight three different types of considerations of model scope. What things are endogenous? What things does a model tell us? Does it produce? We saw that earlier. The model was outputting number of individuals, for example, who are current smokers or former smokers for different SES groups. These are things produced by the model. We put in our assumptions, and it tells us what will be going on over time. There's other things we put in, like hazard rates, that might be exogenous. We specify to the model. We tell the model what to assume for those. Endogenous things the model tells us. This is what happens over time. It's a logical result of what you've told me. Exogenous things we tell it. Assume that you know, the mean SES level is this, and the standard deviation is that. Assume that SES has this level of effect on risk of initiating at this age or what have you. These are exogenous factors. We tell the model, we inform the model about them, often using empirical data. And then there are some things, many things, that are typically left out of these models. They are omitted from the model because we don't think that they are germane to our situation, or we're not ready to add them in. We want to think through our thinking with a simpler model before adding them in. Or we want to test, are they likely to be important before adding them? Okay, okay, so key take-home messages. I know this has been a long talk, and I appreciate your patience. So, addressing many practical challenges in health and other complex areas is hard because they exhibit features of complex systems. Things in the world are tangled when it comes to understanding how to best regulate e-cigarettes, when it comes to understanding how to confront the rising rates of gestational diabetes and type 2 diabetes in our Aboriginal communities, when it comes to trying to figure out how to reform the provincial healthcare system to allow for more timely treatment of patients in emergency rooms. There's a lot going on there. You think about an emergency room as being a fairly simple matter, but in fact, so many of the delays in our emergency rooms are coming because of systems effects. It's not the fact of how quickly they get treated by the docs there. It's why are the beds occupied? Because the acute care beds are occupied. Why are the acute care beds are occupied? Partly because our long-term care facilities are full and we can't get people out to them. It's about why people are coming in that could have been treated with family practice sensitive conditions, could have been treated by their family physician, but they're coming to the emergency room because of the poor state of rural health care in this province. It's bringing them to the emergency room because they're falling through the cracks of home care in some cases. It's a systems effect. You think of the emergency room as being a contained thing, and what's going on dynamics is just within those walls. It's not. It reflects what's going on throughout the province in complex ways. It's tangled, ladies and gentlemen. System science provides us with ways to reason about these tangled systems, to ask what-if questions, to ask, is this understanding this theory consistent with evidence? And they provide a way of encoding dynamic hypothesis in an operational form, in a way that's less ambiguous and that can communicate to others. And these models help us understand what's going on, why we observe certain patterns, and how interventions might affect things. Models are specific to purpose. We build different models for different things, and multiple and hybrid modeling techniques are going to be complementary for describing them. So I want to thank you for your extreme patience. I want to thank you for your extreme fortitude, because I suspect that many folks might need a break. So thank you very much. We will resume after should we say 5-minute break? 5-minute break? Thanks very much. Yeah.
Brandy Winquist, I'm
Yes.
the conference chair. Good to meet you.
Oh, yes.
Yeah.
Good pleasure.
They're wondering about lunch. So